So we're going to talk about the DSEK procedure itself. First thing I want to talk about, Gladys, is the trephination. Now, the trephination is where we actually cut the 13mm button that we need. In humans, they'll only cut up to about 10mm, but we like to cut just that little bit wider because we know that the white to white of dogs is wider. And so there's only a few things that are key important facts or information that you need with the trephination. The first one is the actual human corneal tree fines. They're the wrong diameter and they're also the wrong radius of curvature. In humans, the radius of curvature is, about 6.5mm. In dogs, it's about 8mm. So if you put a dog cornea on a human recipient block, it's just not going to sit properly, and that's what we found. So we just turn the trephination blocks upside down, put a little bit of Optisol in, and then we use a 13mm tree fine punch, and that seems to work pretty well. Make sure that you do a complete cut. It's really important that when you actually use the corneal tree fine, you make sure that you engage all of the recipient tissue. So one of the things we need to do is we actually need to mark the cornea to accommodate our 13mm graft. And the reason we decided on a 13mm graft is because it's roughly 1mm inside the white to white distance of a dog, which is about 15mm. In humans, the white to white distance is around about 11 to 12mm, and that's one of the main reasons that they actually use a 10mm graft. When we're actually marking the area to score or to mark out on Descemet's membrane on the recipient cornea, what we usually do is use a 13mm corneal tree fine, put it in a little bit of gentian violet, just touch a little bit of gentian violet onto the edge, and then we just try to centre that right over the cornea, and that then gives us a reference point for when we do our desmorexis.
An important aspect of the surgery is to maximize our visualization of the Descemet's membrane in the patient. And in order to do that, prior to surgery, we would have already used tropicamide and phenylephrine to dilate the pupil. To help us intraoperatively, we also inject adrenaline and viscoelastic to help maximize the pupil dilation. Now, that helps us to really get a good reflection of the Descemet's membrane during the scoring as well as the stripping process. And another aspect that we use in the surgery is to use trypan blue to highlight or to stain the unhealthy endothelial cells, and so we can see the blue of the Descemet's membrane stripping off during the surgery. So we mark a 6.5mm corneal groove near the limbus, about 1mm in from the limbus, and that is about half of the width of the donor graft, so 13 divided by 2. And that allows the graft to enter in without too much disruption. There can be a little bit of accordion-like folding, but we try to avoid that as much as possible. Now, if we're using a push-in technique, we do not actually need any other side port incisions. We only need one at 12 o'clock, and that's about it. If you're using a pull technique, then you will need another side port incision at the 6 o'clock position. Depending on our technique and also how the surgery progresses, you may also need another side port incision at other parts of the limbus so that you can readjust the graft using a Sinskey hook to drag the graft into position.
So after we've done the marking of the cornea and the limbal groove, the limbal incision, and some side port incisions, the next thing we need to do is to actually do the desmorexis itself. Now, there's a couple of things you need to remember with that. Probably the main thing is that because we have this floppy cornea, so to speak, with a lack of rigidity, we need to keep it taut. Firstly, we use the viscoelastic, which is the visco-cohesive, and then the other thing is just don't make a very big incision with your side port blade when you first go to inject the viscoelastic. When you actually do the desmorexis, the first thing you need to do is to what we call score. And what score is doing is actually delineating a circle, a roughly 13mm diameter circle, and that's going to be the start of where you do your desmarexus from. Now, we've actually developed some specific instruments called the Hensler instruments, named after Henry and Isla, Kelly's and my two children. These are instruments that we've specifically developed for the dog, for the canine cornea. They just have some allow for anatomic variations to humans. And the first instrument, which is to score with, just allows us to reach across the anterior chamber a little bit better, and also the tooth on it at the end is adjusted for the width of the canine Descemet's membrane. The other instrument that we've developed is actually a scraper. It's a broad-faced scraper. It makes the removal of the Descemet's membrane much easier to do. We've made it to accommodate the corneal curvature of a dog. When you're actually doing the removal of Descemet's membrane, whilst you want to try to be pretty meticulous, if you do happen to, for example, go a bit too deep, get some of the stromal collagen fibres or something like that, it's not the end of the world. It's not a major issue. You can always come back and remove any remnants of Descemet's, or if you've got some stray collagen fibres, it doesn't matter if they get incorporated into the interface. The biggest problem, I think, that we found anyway is the completion of Descemet, of the desmarexus, which usually at the point of entry, it can get quite hard to just keep pulling towards you. So we actually like to push away, try to think of pushing everything towards the centre, push Descemet's to the centre. The problem is with a lot of these Descemet's membranes, though, that you're going to work with is that they're actually fragmented, they're weak, they're unhealthy. And so if you see what happens in the human corneal desmarexus videos, they'll often remove it in a beautiful circle and you think, oh, why can't we do that? Well, there's a good reason. The reason is that human Descemet's membranes are much stronger and tougher than canine Descemet's membranes. So it's probably the hardest step, I personally think, the biggest skill that you need to learn as from what we do routinely as veterinary ophthalmic surgeons, but it's also probably the most crucial step. What do you think?
Yeah, I think we're looking really clean. Once we finish the desmarexus, we would then plan for viscoelastic removal. And prior to removing the viscoelastic, it is very important to decide what you're going to do before removing it. So it depends on whether you're going to use a push-through or a pull-through technique. If we're using the push-through technique, you will remove the viscoelastic after placing an anterior chamber maintainer. If you are using a pull-through technique, you will first do a side port incision at the 6 o'clock position to allow the suture to go through the anterior chamber and through the 6 o'clock position, and also place an anterior chamber maintainer before removing the viscoelastic. It is very important to realize that after the viscoelastic is removed, you might anticipate the anterior chamber to collapse because of the lack of rigidity of the canine cornea. As a result, the anterior chamber maintainer should be ready to have fluid flowing through it before you actually remove the viscoelastic. On top of that, it is very important to remember not to let the tip of the anterior chamber maintainer touch the lens. To prevent that, you may want to have the tip of the anterior chamber maintainer over the iris so that in the case of any collapse, it will not touch the lens.
So we're now at a part of the surgery where we need to get the graft actually into the eye itself. Now, there's two ways to do it. There's a push-through technique and there's a pull technique. And the push technique is the one I personally prefer. I think it's a quicker technique. And basically what it involves doing is getting a sheets glide, putting it through that 6.5 millimetre limbal incision that you've done, or incision 1 millimetre in from the limbus, and you need to put the sheets glide about half to 3/4 of the way across the anterior chamber. Then what we do is we've got the graft, the donor graft. It's going to be endothelial side up on the recipient corner. And then what we need to do is we need to then flip it over so that the endothelial side is down on the sheets glide. Now, you'll have also just put it in a little bit of a visco-cohesive on the sheets glide to protect the endothelial cells. Put the endothelial side down of the graft, and then use an instrument such as the Hensler scorer or a reverse Sinskey hook, something like that, and then you literally push the graft in as your assistant is opening the wound, and as you push in, you're going to pull out the sheets glide at the same time. So you're creating that space. Then you're pushing the graft all the way across the end of the sheets glide. Then what you do is then just put in a single interrupted suture just at that 6.5mm incision. So that's if you're doing a push technique. If you're doing a pull technique, there's a couple of different ways you can do it. Probably the safest way, certainly in an animal that's still got its lens, is to actually use suture material. And what you need to do basically is the side port incision that you've done at 6 o'clock, we need to somehow get suture from that entry point across to your 12 o'clock incision site and attach it via 9O-ethylon or 8O-ethylon on a spatula needle or a cutting needle. And you've got to take a full thickness bite through the donor graft, and then basically you're then going to try to pull it right across the whole of the anterior chamber. The biggest problem I personally have found with doing that technique is that the 9O suture it's pretty easy to snap as you pull it across. You've also got to make sure that you pull the suture right through the middle of the incision. If you go off to the side slightly, it'll torque and it'll rotate and you'll snap the suture. So I personally find it's just a little bit more fiddly to do, but both of them are very, very viable techniques to do. I've done both techniques, and as I said, I just prefer the push-through technique.
After the donor graft is inserted and a simple interrupted suture placed at the entry point, you can then place an air bubble into the middle of the anterior chamber underneath the donor graft. It is very important that it is the cannula that you're using to inject air bubble into the anterior chamber is underneath the donor graft. And to ensure that, you can use the iris as a point of reference. So if your cannula is sweeping across the iris, not touching it, you can then gently direct the cannula to the center of the donor graft and inject a small air bubble. At this point, a large air bubble will not be very helpful because it may actually move into the interface. So use a small air bubble at this stage. If you happen to put the cannula into the interface between the donor and the recipient, it is just as easy to aspirate the air bubble at that point so that you regain that contact between the donor and the recipient. After placing those simple interrupted sutures, we can then go back in with the cannula to re-inflate the anterior chamber. So it is important that the cannula joins back into where this initial air bubble you have placed so that the air bubble stays as one big air bubble. Now, if your graft is not centered at this point, you can either use gentle sweeping motions using the Hensler hook or the reverse Sinskey hook over the surface of the cornea to try to move your graft in place, or you can do a tiny little side point incision at another point of the limbus so that you can pull the graft over or towards the area of the incision using a Sinskey hook or a Hensler hook. Now, in our experience, we find that it is a lot easier to use the reverse Sinskey hook or the Hensler hook to pull the graft towards the incision than to use the sweeping motions over the cornea. This is because the canine rigidity of the cornea is very different from a human. And so what seems to work very well in a human using sweeping motions does not work very well in canines. So once you have hyperinflated the cornea, you will measure the pressure to be about 20 millimeters of mercury and keep it hyperinflated at that pressure for about 10 minutes. And afterwards, the surgery is done.
I wouldn't be surprised if this guy has an excellent outcome.